So a client with a 20 years history of schizophrenia and is hospitalized. The client appeared the visible upset and approached the nurse and saying in a shaky voice, I cannot find my headband. I cannot find my headband. 2 times said. The well is going to leak out of the crack in my head. So my patient is diagnosed schizophrenia. This question is easy because of this key point. So when you see your patient is diagnosed by schizophrenia, you understand maybe your patient have a false belief or auditory process or perceptual problem, right? Or misperception of stimuli or sensory perception, because all of this is the character of schizophrenia. You know, because you are the person who going to sit for the exam. You are the healthcare provider. So what are the best response? There are 4 options. So already you know your patient has a psychotic disorder. You are smart enough, you do not tell them you are wrong. It can increase the patient anxiety, right? You pretend, okay, let's go and check with you. Then you explain more. So, one, how long has the well been leaked from your head? So this is the abnormal. You know, we know, but your patient does not know because they do not have a sense with reality. They have a false belief. If you ask something like this, it means you encouraging them their false belief. Don't go for this. Do not go to encouraging the false belief or misperception. Also, don't stop it in one single word. Go and give them the value, significance. Yes, you have a problem. Let me explain. Let me check. Let me work together. We call Milu therapies. So, number 2, let go back to your room and look for your headband together. So your patient understand you are the person who go to work with the patient. Then you can find out and explain more. Number 3, there is no well coming out of your head. It is absolutely again to your patient false belief. You know that, but you can't say this. You are going to miss your breakfast if you do not go into the dining room. The number 4 does not match with this question. Nothing related to the breakfast we found here, right? And also it is irrelevant. So number 2 is a good explanation. And schizophrenia, it is the psychotic disorder. It affects the thinking, it affects the behavior and also emotion, and also the ability to perceive the reality. And schizophrenia probably the result from a combination of genetics or neurobiological or non-genetic sometime, like injury at the birth. Patients suffer with the schizophrenia. So this patient sometime they difficult to survive independently. Let me go and explain first what they said. The client, while delusion is exhibit the sign of anxiety, the priority action for nurse is intervene in a manner that will assist in reducing the client anxiety, right? The headband is a part of the client delusional system. It is highly likely that the client will continue to be apprehensive until the headband or substitute is found. Offering to help the client look for the headband convey the sense of caring and help the established a trusting relationship. So next time they come to you to ask something, then you ask the leading question. What leading question, my friend? Because the patient who is schizophrenia, they feel hopelessness and they have a suicidal ideation. So when they found the trust in you, they can verbalize their feelings and you can find out they have any suicidal ideation or not. This is the most important. Safety is the most priorities. Once the client have claimed down, the nurse will minimize any conversation, right? Any conversation about hopelessness, about suicidal ideation, or any kind of cognitive symptom, negative symptom you can find out, or positive symptom you find out by conversation. Delusion are fixed, false belief that are accepted by the client as real, cannot be changed by logic, by reason, or by persuasion. Category of delusion include the following. So now we are going to the category of delusion. Before to go the category of delusion, I want to share with you three terminology. What is delusion, what is illusion, and what is hallucination. So delusion, it does mean a false fixed belief. Illusion, misperception of a stimuli, and hallucination, sensory perception, but there are no stimuli, right? So now I can tell you what are the different kind of delusion for the patient. Let me go and let me explain. Here, one is called persecutory or persecution, idea of references, grandiosities, and somatic. So first one, they said persecutory or client think others are out to get me. They have abnormal belief. Idea of reference, common events refer significantly to the clients. And grandiosity. So client has perception of a special importance or power that are not real stakes. So they thought I have the ability to talk to the God. I'm the person who talked to the president over the phone every day. So they thought about this. I'm all in all. Hmm? And somatic false ideas about the bodily functioning. I feel something in my body that other does not feel. Somatic. Nursing intervention include the followings: not argue or not challenge the patient, reinforce reality, but by talking about encouraging the client to participation in real events. The nurse should not delve into or have a long conversation about the delusional belief system. So the problem with the thinking and makes it very difficult for the client to live independently because they have disordered thinking or inability to make the decision. They have a poor problem solving ability or difficulty concentrate to the problem tasks, memory deficit, long-term memory loss, or they have inability to follow the direction to find even any address. So all of this makes them very difficult for the client to live independently. Even they feel very hopelessness or they have a suicidal ideation. So when we deal with the patient, it is very important to uh, nursing care, right? Or when you deal with the patient, we try to encouraging them, including the melotherapy, because the patient-centered care is super important for them. Melotherapy is used for the client who have a psychotic disorder. And also we could provide a structural and safe environment because it is the first focus for melotherapy. And also program of assertive community treatment, very important. And also some medication can help to overcome the schizophrenia. What are the education objectives? The priority of nursing action for the client exhibiting anxiety is to intervene in a manner that helps to make the client feel more at ease. Delusional fixed false belief and challenging a client delusional content system will increase the client anxiety and will not change the client belief. So if you ask me what are the treatment for them, we basically we used to treat mainly the psychotic patient by haloperidol or chlorpromazine we use. Even sometimes we use by second generation medication we call like risperidol, olanzapine, or clozapine. Question here: the daughter of a 80 years client recently diagnosed with Alzheimer disease, saying the nurse, So question come from the daughter of the client, and your client diagnosed with Alzheimer's disease. Your client 80 years old, but question come by the daughter, right? And daughter saying, I can anticipate getting this disease myself at some point. What are the best response? So Alzheimer's disease is a neurogenetic disorder, and it is very important. This disease is related to the aging process, right? It is a neurocognitive disorder, and this disruption of the patient thinking, memory, processing, and problem-solving abilities. As I told you, it is related to the aging process. And this Alzheimer's disease resulting in gradual impairment of cognitive function, and it is most common type of the neurocognitive disorder. And you know, the Alzheimer's disease is a common sign of forgetfulness and delirium and dementia, most important. And when we take care of the patient, the nursing care is important for them. And Alzheimer's disease, the cause is unknown. But some books said the patient who diagnose Alzheimer, they have a decreased acetylcholine or patient lack of acetylcholine. And who is affected most? If the patient is 65 to 85 years, and also the affected men. And some books said the affected men and female are equal, right? Equal. So most common symptom of Alzheimer, gradual loss of cognitive function, and they have a forgetfulness is common or cannot perform the purposeful movement. So your patient tells something out of 4, which is your response, best response, right? Have you suffered any recent head trauma? This is a good question, because if the patient have a history of major head injury, they have a chance to develop Alzheimer in future. But which is the best option? If you modify your lifestyle, you can reduce the risk of familial Alzheimer disease. Lifestyle is related, but there are no clue found that Alzheimer is very strong support of family history. It is a good that you recognize this now so you can plan for future care. Okay, so number 4, not necessarily the strongest known risk factor Alzheimer is aging. So number 4 is most related to Alzheimer, because Alzheimer disease is strongly associated with patient aging, right? So here, what are the explanation of it? They said the Alzheimer's disease most likely caused by combination of genetics, environmental, and lifestyle factors. However, according to the National Institute of Health, the strongest known risk factor for late onset of Alzheimer is advanced age. Most clients with Alzheimer receive the diagnosis after the age of 60. The chance of developing Alzheimer disease double about every 5 years after age of 65. At the age of 85, the risk developing of Alzheimer 50%. So Alzheimer disease, shortly called E and D, right? So A for Alzheimer, D for disease, and A for acetylcholine. So if the patient decrease the acetylcholine, patient lack of acetylcholine, chance to develop Alzheimer disease. It is very uncommon. Alzheimer has a known as a familial Alzheimer. Multiple generations are affected. Signs and symptoms may appear during the early to middle adulthood, and diagnosis made before 60 years. And the diagnostic criteria: health history, family history, or EEG, encephalography, MRI, or CAT scan. If you ask me about the treatment option, definitely supporting management or care, give them medication, increase the acetylcholine or doneprazole. Also, supportive care is very important for your patient. And here this development of Alzheimer disease is influenced by combination of genetics, lifestyle, and environmental factors. The most significant and strongest risk factor, later onset and advanced age, right? So when you're dealing with the patient who have Alzheimer disease, nursing intervention are focused on protecting the client from injury. This is the question NCLEX would ask, as well as promoting the client dignity and quality of life. So let me recap one more time. Provide for safe and therapeutic environment is super important if our patient has a Alzheimer. So we assess for potential injury such as the fall or wandering. Again, also assign the client to a room close to the nurse station for close observation. Also, we provide a room with a low level of visual and auditory stimuli. We provide for a well-fit environment and minimize the contrast and shadow. So have the client sit in a room with a window to help with the time orientation. Also have the client wear an identification bracelet and use monitor and bed alarm device as needed. Sometimes use the restraint only as an intervention of least resort, and also use some precursor when administering the medication for agitation or anxiety. But I want to recap one more time. The assessment for the client risks for injury or ensure the safety in physical environment such as, prevention the fall is most priorities. Question here, a client with diagnosed with schizophrenia with a catatonic has recently been admitted to the hospital unit. Which of the following is the priority of the nursing diagnosis? So my patient is diagnosed with schizophrenia, is okay, but the patient has schizophrenia with catatonic behavior. So if your patient is extremely bad condition, very severe schizophrenia, that times we can see the catatonic behavior. So basically, the catatonic schizophrenia, very uncommon and severe mental disorder. We characterized it by striking motor behavior. So they do something abnormal bodily or hand or legs for a long time, abnormal posturing for a long time, typically involving either significant reduction in voluntary movement or hyperactivity and agitation. In some cases, the patient may remain in a state of almost complete immobilities. So if anybody is completely immobile or immobility or a bizarre posturing, they do not eat, they refuse to drink, they have a chance to develop some bodily problem, right? As I told you, catatonic schizophrenia is one of the feature of very serious mental illness. It is a psychosis. And keep in mind that catatonic schizophrenia affect the way you move in extreme ways. Sometimes the patient is totally still, same posture, or they still mute. They do not talk, they do not eat, they do not drink. So in that condition, as a healthcare provider, which should be most priority of nursing diagnosis? So impaired the social interaction. It is nothing. The psychiatry patient is common. Impaired the verbal communication, very common. It is not life-threatening. Risks of impaired skin integrity. So we prevent the skin integrity if any chance. They said risks of. It's good choice, but what are the life-saving? Risks for deficient of fluid volume. So if your patient has a catatonic nature, absolutely mute, absolutely same posture, refuse to drink, refuse to eat, they have a chance to develop dehydration, volume, fluid volume go down, patient chance to develop hypovolemia, dehydration, and they undergo to the shock and they will die. So it is the most priorities, right? Identification of the problem. So what is their explanation? A diagnosis of schizophrenia with catatonic can made if the client have a feature meet the criteria of diagnosis of schizophrenia, include at least two of the following additional feature. So in my lecture, what I gave and what I left in our NCLEX timeline, I explained what are the positive sign, what are the negative sign, and when you diagnose a patient. Usually the positive sign are hallucination, delusion, or alteration of the speech or bizarre behavior. And negative sign very common, like if our patient like narrow range of expression, affect, or elogia, poverty of thought or speech, lack of energy, lack of pleasure of joy, or lack of motivation in activities. It is negative sign. What else? They said immobility, extreme uh, cases, or remaining mute. So, or in immobility, they refuse to move, right? Or sometimes excitement or hyperactivities. Bizarre posture, the client hold the body rigid for a long time in same posturing. Extreme negativism, the client resist instruction or attempt to be moved, right? And also the stereotype movement or promote the gramicities. And as I told you, sometimes uh, they have a lack of motivation in activities and hygiene, or lack of pleasure of joy, or lack of energy, or poverty of thoughts and speech, or very narrow range of expression. We call flat expression, or facial expressions never change. The client with catatonic schizophrenia are unable to meet their basic need for adequate fluid and fluid intake and are at the high risk for dehydration and malnutrition. The priority of nursing action is to anticipate the client needs and to ensure that the client is well hydrated and has adequate nutrition, right? And some client will need to total care. But most important to prevent the dehydration or volume fluid overload. The client, what is education objectives? The client with catatonic schizophrenia are unable to meet their own needs for fluids, food, and movement. Even elimination of bowels or elimination of urine. So need assistance in performing the basic activities of daily livings. However, the priority of diagnosis, the deficit fluid movement. So I said, always we could provide patient-centered care, what is good for the patient. Question here, the nurse perform an initial assessment on a client with suspected post-traumatic stress disorder. In this question, we found our patient is suspected to diagnose post-traumatic stress disorder, shortly called PTSD, which assessment would support the diagnosis of post-traumatic stress disorder. So if you know what are the common characteristics or presentation, sign and symptom of post-traumatic stress disorder, it would be easy to find out the answer. Select all that apply. There are 5 options. Which one should be the answer? So the person who diagnosed the post-traumatic stress disorder usually exposure to a traumatic events in their life, like physical assault or rape, or physical abuse like military combat more common. And all of these are exposed to the traumatic events that can cause some of the manifestation of the disease. Like here it is. Usually, patient present with difficulty of concentration or feeling of detached from the others, feeling of lethargy or apathic, feeling of lethargy is not that much oriented to the post-traumatic stress disease, but flashback of the traumatic events on of the manifestation or persistent angry or fearful mood. So let me recap it. As I told you, the most common manifestation are flashbacks or distressing dream, nightmare, or difficulty of concentration, or insomnia is most common, anxiety, irritabilities, or detachment from others, hypervigilance, or exaggerated startle response. Also, some of the client feeling of guilty and negative self-image, most common manifestation of post-traumatic stress disorder. So in this question, we are going to learn what are the presentation of post-traumatic stress disorder. What is their explanation? Post-traumatic stress disorder may occur in the people who have seen or experienced terrified traumatic events in the life, like war, tornado, rape, physical abuse, military combat, or plane crash, if they survive. There are three categories of post-traumatic stress disorder. What are the, let me read the following manifestation. They categorize in the three. One is called re-experiencing traumatic events, then avoiding the reminder of trauma, and also increase the anxiety and emotional arousal. Number one here, example include intrusive memories, flashback, recurring nightmare. As I told you, it is very difficult for them to sleep, insomnia, anxiety, irritability, or bad dream is most common. Feeling of intensive distress, loss of control, or strong physical reaction to events, remainder. Even sometimes physical manifestation like gastrointestinal distress, too much sweating, diaphoresis, or profound heart. Avoidance, reminder of the trauma. Example include avoidance of activities, places, thoughts, and other trigger that could severe as a reminder, serve as a reminder, or feeling the detached and emotional numb, loss of interest in life, or inability to set the goal. Sometimes short-term memory loss, amnesia. So increase the anxiety and emotional arousal. Example include insomnia, irritabilities, outburst of rage, persistent anger or fear, difficult of concentrating, and hypervigilance or exaggerated startle response. So, detach from others or hypervigilance or exaggerated startle response. Even some patients sometimes feeling of guilty and negative self-image. They are victimized, but they blame themselves, feeling of guilty, but it is not their fault. Post-traumatic stress disorder. So treatment of option about them, what they said, education objectives, a person suffering from post-traumatic stress disorder experience the three categories of symptoms. Here they explain re-experiencing of trauma, avoiding reminder of trauma, and hyper arousal. So if you ask me what are the treatment options, definitely the cognitive behavioral therapy can work, or prolonged exposure therapy, like combined with relaxation techniques, work very well. It works. Eye movement desensitization or reprocessing, or some medication like SSRI or SNRI or TCA or tricyclic antidepressant work very well. Other treatment option we choose like biofeedback or hypnotherapy also works.